Brian,
Hey, how's it going?
fantastic. How you doing?
Good.
I don't know how that backdrop got on me. I don't know how to fix it.
That's fine. Um, Maybe if you go to like video settings, I think there might be something in there.
That's funny. Let me figure this out. My kids were on my phone earlier, so uh, meeting settings, backdrop maybe,
Yeah, probably.
background and effects. There we go.
There we go.
Perfect.
Okay. Okay, so I just got like, I think it's like 9 questions maybe. Or no, 15 questions. Yeah.
Okay.
Pretty good question. Short. Okay. So first question is, what made you choose anesthesiology?
Uh, Great question. So when I was in my third and fourth year of medical school, you do clinical rotations, and going into medical school, I was thinking orthopedic surgery. Um, I played sports growing up. I had a couple of friends whose dads were orthopedic surgeons, so that was kind of the mindset. But once I did where I went to school in Kentucky, University of Louisville, we had to do a 2 week rotation in anesthesia because the dean of our med school was an anesthesiologist, so required all students to do 2 weeks. And then so I did my 2 weeks and loved it, and extended another 2 weeks. We had to do a rural health rotation, so I was able to work at a small hospital where they put you to work and let you do anything and everything. So as a third year medical student, I was doing I starting IVs and intubating and uh, helping with epidurals. They let me do a few epidurals with coaching. So I thought this is it. Loved it. So didn't look back from that point forward.
Yeah, it's definitely my top three too, because I definitely want to do in like some type of surgery. So
Yeah.
like anesthesia is definitely a top three right now too.
Yeah. I mean, it's procedure based. So every patient you're doing
Yeah,
something invasive to them. So yeah, it's
yeah,
awesome.
yeah. Okay. What do you find most challenging about your career?
Um, Probably the complexity of medical issues that some patients have. Um,
Yeah,
Work-life balance is pretty good.
yeah,
Once you leave work, I mean, you finish that last case of the day, you're not taking anything home with you, which is great. So I don't have to worry about an office. I don't
yeah,
have to worry about HR or personnel, or
yeah, yeah,
you show up, you turn the machine on, make sure it's working properly, find your medicine drawer, and everything's pretty uniform in terms of all the facilities we go to. They're all about the same. So it's kind of plug and play and get to work. So it's good.
yeah. Okay,
Yeah, probably the elderly patient with multiple medical issues, those are challenging
yeah.
in terms of day-to-day things. But outside of that, yeah, it's a pretty good lifestyle.
Okay, what are the factors that go into play when like you're giving the anesthesia to patients?
Uh, it's going to depend on the what the procedure is. It's going to depend on um, if there's anything that would harm that patient in any way. The first rule of medicine is first do no harm. And so anytime I'm giving a medicine to a patient, I have to think, is this going to hurt them in any way? Maybe they have an allergy, maybe they've had a bad reaction, or maybe they have a family history of malignant hyperthermia or some adverse reaction to anesthesia. And so I'm thinking, is this going to trigger anything that's going to cause them to not do well? Um, so there are various modes of this, is kind of a saying in anesthesia. There's lots of different ways to skin a cat, and so you can get a patient through about any procedure with multiple. I may do it one way, my partner may do it a little bit differently, and someone else may do it completely different. But the end result is the patient wakes up and uh, they're comfortable. So uh, that's kind of the art of anesthesia, is how you do things day to day, how you get that patient through a procedure. But and some areas are patient or is procedure specific. So if I'm on OB, I'm going to be either doing an epidural or a spinal for a C-section.
Yeah.
If I'm doing a total knee, the surgeon may request a spinal in addition to a regional block for post-op pain control. So some of it's driven by surgeon preference, and then most of it's driven by the health of the patient and what they're going to do best with.
Yeah. Okay. And what new technologies or techniques have changed in the past recent years?
Yeah, good question. I would say the use of ultrasound machines. So when I did my training, I finished in 2008. So I've been out 17 years. So when I trained, we did not have ultrasound machines to help us with nerve blocks or to help us with central lines, or, they were just coming into play in the trauma bay with, belly scan to see if there's acute injury anywhere. The use of ultrasound and the technology and the clarity of those that's a game changer for us. Medication wise, there really aren't a whole lot of new medicines, except for there's one reversal agent. So if we give a paralytic to put a breathing tube in, we used to have to use a couple combination of different medicines and then wait time for those to take effect. Now there's one medicine that reverses the effects of that paralytic immediately. So that's a game changer.
Yeah.
So probably ultrasound and the use of Sugamadex is that medication.
How does a patient's health affect how the anesthesia works on them?
My primary concern is what's the patient's cardiac status and what's their pulmonary status. So if they have a healthy heart with a good ejection fraction and good lungs, I can get them through any procedure. If they have a weak heart, say the ejection fraction, if they're in a heart failure, maybe it beats at 20% efficiency rather than a normal would be 60 to 65. So if it's a weak heart with bad lungs, it's going to be a battle. It's going to be a challenge. Say someone's been a long-term smoker, so they have COPD, or maybe they worked in the chlorine business and have pulmonary fibrosis or scarring of the lungs. Those are challenging cases to be able to take that breathing tube out at the end of the case. When surgery's done, just you don't know how strong their lungs are going to be.
Yeah.
So those are the biggest comorbidities or kind of health factors I worry about, is what's their pulmonary status and what's their cardiac status.
Yeah. And then, so why is it important for anesthesiologists to understand how drugs move throughout the body?
Yeah, it's every patient's going to react a little bit differently to the medications. So it's understanding their health history, and it's understanding their metabolism. So people are going to metabolize local anesthetics at different rates. They're going to metabolize pain medications differently. And so it's kind of understanding what the physiology is of that patient. So if I can know that they have good kidneys, they're going to metabolize medicines pretty well. If their kidneys are bad and they're in renal failure, then the medicines are going to hang around a lot longer, just because the first pass effect through the kidneys and the liver is not going to do much to that medication, so it's going to linger longer. So everyone's going to react a little bit differently to the meds. That's kind of getting to know that person's physiology while they're asleep. That's kind of the fun part of anesthesia, is knowing how they're going to react.
Oh yeah. How does the brain process pain, and how do anesthetics stop someone from feeling it?
Yeah, good question. So the brain, we're basically shutting down the pain signals in the brain. with the anesthetics. So we give either IV medications or after we intubate the patient, we connect them to the ventilator and turn on anesthetic gas. That gas is absorbed through the lungs into the bloodstream. It goes to the brain, and it hits different receptors and areas of the brain that basically make that patient not feel pain. And it's pretty incredible. And we really scientifically don't understand how exactly the volatile anesthetics or the gases work, but they work. And it's crazy to think with all the advances we have, no one can really pinpoint and tell you this is where it works and this is the mechanism.
Yeah.
The IV medicines we give work differently. So the propofol is one we give to put them to sleep, and that works on GABA receptors. And the narcotics we give work on mu receptors in the spinal cord, so that they limits that pain or that sympathetic response they have. And so it's kind of understanding, and we don't have 100 different medicines. Basically, it's pretty simple what we use, but it's just understanding how long is that medicine going to take effect, and where is it going to work to get them comfortable. So the whole goal is for them not to feel pain. And so it's understanding what to target to make that happen.
Okay. How do concepts like air pressure and gas flow help anesthesiologists give the right amount of anesthesia?
I know this is get deep. So so that we work with partial pressures of oxygen and air and gas and air. So air is 21% oxygen. We typically run these patients on a fractionated inspired oxygen level of maybe 60 to 70%. So it's an oxygen rich flow into their lungs. And that oxygen, that flow of mixture of oxygen and air is going to carry that volatile anesthetic into the lungs, get absorbed, and go to the brain. So if I'm working at sea level versus at 7,000 feet, there's going to be different partial pressures of oxygen I have to consider in terms of how much is entering that patient. We have the ventilators are pretty advanced to where we can just dial in what percentage we want, and that machine delivers it. It's pretty incredible. Same with respiratory rate, and same with volume. How much volume is going into that patient versus what's coming back of that air mixture. We can kind of dial that in and determine how much to give and how frequently. So it's the technology is pretty.
Okay. How does the structure of anesthesia drugs affect how strong they are?
So it's if you can picture like a lock and key, that's how my brain works. So it's if every drug has a chemical composition to it that's gonna bind to certain receptors. So for example, if I think of Piperidine, which is Demerol, which is a pain medication, and atropine, which is an anticholinergic, those drugs look very similar except for one component of it. So it's pretty amazing how one will lock into that receptor and the other one won't, and cause certain effects in the body. So that chemical composition determines uptake and how quickly it happens. And so say, for example, lidocaine, a local anesthetic, it's going to disrupt the flow of sodium and potassium at that channel to where that signal from the brain that there's an afferent and an efferent system. So if I touch a hot stove, that's going to quickly go to the brain and tell me, hey, pull your finger off. That's going to burn. Ouch. And so that lidocaine interrupts that signal to where that person will not feel that pain sensation. So it's pretty incredible.
Yeah.
And each of those medicines work at different strengths and at different rates. So you can kind of dial in how long you want that effect to take.
Yeah. Why does the way anesthesia dissolves in the blood affect how quickly it works?
I couldn't hear you on that last question.
Oh, why does the way anesthesia dissolves in the blood affect how quickly it works?
Yeah, so it's going to be the quicker the uptake into the blood, the quicker it gets to the brain. Like an example I can think of is someone in heart failure. If that heart is not squeezing effectively, and say it's a rate of 40 beats per minute versus 80 beats per minute, that's going to determine that 40 beats per minute may take a little bit longer to get that blood effectively to the brain rather than 80 beats a minute and at a ejection fraction of 60%. So that blood solubility is uh, determining how quick that blood gets to the brain.
Okay. How does a patient's pH levels change how the anesthesia works?
Let me see. An example I can think of would be, say someone has a cut on their finger and that cut gets infected and there's pus in there. That's going to lower the pH to make it more acidic, to where if I try to give local anesthetic around that site to maybe suture up that wound, that acidity is not going to allow that local anesthetic to be effective. And so you basically have to drain the pus out and let that body clear that infection for that local anesthetic to work. And so the either high acidity or low pH or a high pH, more alkalotic, the medicines are not going to be effective.
And then one last question. How does the body break down anesthesia drugs and why is it important for recovery?
Yeah. So body, your kidney and your liver are your main metabolizers of the medications. So they'll circulate through the system, they'll hit the kidneys, and the kidneys will filter out some of the drugs and start to break them down. Majority of the drugs go through the liver. So propofol goes through the liver. All the pain meds go through the liver. And so if someone has liver issues, maybe they've been a long-term drinker and have a cirrhotic liver, that liver's pickled, and that's not going to be very effective at clearing those medications. So your medications are going to last a lot longer in a patient who's cirrhotic. So it's kind of assessing that full body of that person, their physiology, and then determining what's the safest way to get them through the procedure. So that's the art of the anesthesia, is kind of assessing each patient and understanding this patient's pretty sick. They're not going to need much anesthesia. If this patient's 85 years old, they're going to need just a few molecules of anesthesia to get them through.
Yeah.
Rather than a 20-year-old redhead who's going to need twice as much as you or I. Just genetically, they metabolize medicines much faster, so they need twice as much.
Yeah.
So every patient is going to respond a little bit differently. That's the art of anesthesia.
Yeah. Well, thank you. That's all the questions I had.
Oh, perfect.
Yeah. Thank you very much for your time.
Absolutely. Yeah. Thanks for setting that up. Happy to help.
Yep. Yep.
All right. Have a great day.
You too.
Thank you.
Bye.